Good morning to all. Today we are starting with a new topic, mineral metabolism. To start with, the nutrition. The food that we take or the nutrition is divided into two types, micronutrition and macronutrition. Macro, the name itself indicates macro, it requires that is required in larger amounts. Micro means the things that are required in smaller amounts. So macronutrients we have to consume in larger amounts to have energy. Micronutrients we have to consume in lesser amounts. The nutrients that are included in macro category are carbohydrates, lipids and proteins. We know that carbohydrates are required for energy purpose. They help in mainly digestive system. Basically, we take carbohydrates to provide energy to the body. Lipids. The lipids are required for the structural support for normal cellular function. Along with that, they are stored form of energy in the body are lipids. Now, what about proteins? Proteins, they regulate all the cellular processes. They provide mechanical support and in some extent, they provide support to the body. So, carbohydrates, lipids and the proteins, they are involved in all the enzymes. Most of the hormones all are made up of proteins. So, these are required in a larger amounts. That is why we call them as micronutrients. As they are required in larger amounts, we call them as micronutrients. Now, we call them as macronutrients. Now, about micronutrients, we require it in smaller amounts. They are of three types: vitamins, minerals and phytochemicals. Vitamins and minerals, they have to be taken in the diet or else deficiency manifestations can occur. Whereas phytonutrients, all these things are not so much required. But if you consume them, they help in increasing anti-inflammation. They provide anti-inflammation. They could be antibacterial. They will be acting as antioxidants. All these things, like some of the vegetables that we eat raw, all those things, they are required. Like all the raw things, some of them, they do not per se provide the nutrition, but they help in increasing the immunity of the body. Now, what are the two important things that are included in the micronutrients are vitamins and minerals. We know vitamins, they are required for cell function, development, growth. They also act as antioxidants. Some of the vitamins act as coenzymes in the reactions. And we also know that vitamins are of two types. You have fat-soluble vitamins, water-soluble vitamins. They are so important that if there is deficiency of these vitamins, it will lead to manifestations. Next are minerals. The minerals they required for the formation of the bone, they required for muscular activity, they are required for normal cardiovascular function, because cardiac is nothing but a muscle, nervous tissue normal functioning for the production of enzymes and hormones. Some of the minerals will act as cofactor in the metabolical processes. So these minerals are required for the reactions in metabolical processes. So today we are going to talk about minerals. In this your first internal portion we are including only calcium and iron. Remaining elements will be including in subsequent classes, but for this first internal assessment you have only calcium and iron. Now we have decided on the dates of internal assessments. You will have it on 28, 29 and 30, that is Monday, Tuesday and Wednesday. The day one you have 28th you have biochemistry, 29th you have anatomy, and 30th you will be having physiology. And regarding biochemistry, you will have 100 marks paper that will include 2 essays, 5 shorts and 10 very shorts. Details of the pattern and all that I'll post in your WhatsApp group. And the portion is what I have sent you in the group, the whole thing. Don't think that the ones that are ticked with pencil and all that, all the, I think 1 to 10 I think given, all of the things that I have posted in that are included for your internal assessment. Now, minerals. We talk about the minerals. Minerals are n number of minerals we have, but body won't be requiring so many minerals. We require some amount of minerals, and these minerals are all these things. So each type of the food is rich with one particular type of the mineral. Now these minerals are again divided into macro minerals are major elements and micro minerals are minor elements. And what is the basis in which they are divided into this are macro minerals if the daily requirement is more than 100 milligrams. If you have to take 100 milligrams per day, the RDA is 100 milligrams per day, then we call them as macro minerals. If the RDA means required daily allowance. If it is less than 100 milligrams, it is classified under micro minerals. So what are the minerals that are categorized under macro are calcium, magnesium, phosphorus, sodium, potassium, chloride and sulfur. The ones which are classified under minor minerals are iron, iodine, copper, manganese, zinc, molybdenum, selenium and fluoride. So in this first few classes, we will cover only calcium and iron. All the minerals are important for your exam purpose. So remaining minerals will complete in the next subsequent classes. Now it will be very easy for you to understand calcium because in physiology you have already covered the parathyroid hormones. Hormones are over, parathyroid hormone is also over. So it will be very easy for you to understand calcium. So today we will cover calcium. Now, calcium. Calcium is the most abundant mineral in the human body. If you imagine 1300 grams means 1.3 to 1.5 kgs of the body constitutes the calcium. So, of which 99% of the calcium in the body is present in bones. 1% is present inside the cell and 0.1% is present extracellular. Total plasma calcium level is 10 milligram per deciliter, and the range, usually we have to give the normal values in a range. So because we don't have specifically one value, the value has to be given in a range. So the normal calcium level, the normal reference values for the calcium are 9 to 11 milligrams per deciliter. It is always important to mention the units of that milligrams per deciliter of the plasma. So 9 to 11 milligrams per deciliter. And you can imagine how narrow is the range, 9 to 11. And if the levels are below 9 or the levels are above 11, it is very tightly regulated. So because the range is very narrow, the regulation of calcium is also very strict. And calcium, it is a mineral and calcium is an ion. So it will be existing in different forms in the body. So total body calcium exists in two forms. One is protein bound. 40% of the calcium is bound to albumin. We have seen in the previous classes when we are talking about the plasma proteins, about the functions of albumin. Albumin acts as a carrier protein. So another important function of the albumin is to carry the calcium. So protein, it is 40% of the calcium is bound to protein. Then next is ultra filtrable, that is freely available. So in that 60% of it, in that for 10% of it is complexed with other anions and 50% exist as ionized calcium. 50% of this exists as ionized calcium, and this is the one that is required for metabolic processes and all that. This ionized calcium is used. RDA, that is required daily allowance. Adult will be requiring up to 500 milligrams per day. Children would need up to 1200 milligrams per day. The requirement increases in pregnancy and lactation. So in pregnancy and lactation, it is the amount that is required is 1500 milligrams per day. After 50 years of the age, osteoporosis occurs. That is, the bone will be losing the mineral part. So in order to prevent that, in order to protect the bone, the calcium has to be given. And the calcium, in order to increase the absorption of calcium, it has to be supplemented with vitamin D. Now, absorption of the calcium. In diet, how do you take calcium? In the diet, calcium is taken as calcium phosphate or calcium carbonate or calcium tartrate. So you won't take calcium as such. It is complexed with some other, because it is complexed with some other ions. So it will be in the form of calcium phosphate, calcium carbonate or calcium tartrate. And most of the absorption of calcium occurs in duodenum. The absorption occurs against the concentration gradient, and hence it will be requiring energy because the lumen will have more amount of calcium and all those things. So it occurs against the concentration gradient. So it will be requiring the energy. The factors that affect the absorption. Acidity. Acidity favors the absorption of calcium because it will be splitting calcium phosphate, calcium carbonate and tartrate, and it allows the availability of free calcium. Amino acids, so having protein diet will be increasing the absorption of calcium. Usually amino acids like lysine and arginine increase the absorption of calcium. Now, the most important factor that is required for absorption of the calcium is vitamin D. What does vitamin D do and how does it help in increasing the calcium absorption? Most important is that it induces the synthesis of a carrier protein that is called as calbindin in the interstitial epithelial cells. So in the intestinal epithelial cells, it produces a carrier protein called as calbindin. This calbindin is very effective. Once calcium enters into the epithelial cell, immediately it is taken up by the calbindin. So how does it happen? The vitamin D enters into the epithelial cells. In the presence of vitamin D receptor, it sits on the vitamin D receptors on the DNA and in transcription, and it activates the transcription. The transcription leads to the production of mRNA. That mRNA transcribes and it produces a protein. If you know what the processes occurs, first transcription, if a particular protein has to be synthesized, if body needs a particular protein, so what will it do? First it will provide a signal to the DNA and it will tell that okay, this protein is required. So what will it do? The gene will carry that message, whatever protein that has to be synthesized, it undergoes transcription process will occur, it produces mRNA. That mRNA comes out and in the cytosol that mRNA is translated to form that particular protein. So here vitamin D sits on the vitamin D receptor and it induces the synthesis of protein called as calbindin. So once calcium levels enter, the calbindin binds with the calcium and it prevents again the loss of the calcium into the epithelium. So in this way it acts as a receptor and a sponge that will absorb more and more calcium. Now from the calbindin, the calcium enters into the circulation and into the portal vein. One mechanism is by means of the exchange with sodium and calcium, or it can directly go out through the receptors called as PMCA receptors that are particular to the calcium. So this is already been covered in vitamin D. So once again I am repeating, the vitamin D induces or increases the transcription of the calbindin protein. So it increases the transcription. As a result of that, the transcription, the mRNA that is formed, it is translated and it will form calbindin protein. This has got enormous capacity to hold the calcium. So calcium once enters into the intestinal cells by the receptor TRPV6 receptor, it is taken up by the calbindin, and from the calbindin it goes out either by PMCA receptors or by sodium calcium exchange. So this is how vitamin D helps in absorption of calcium. If vitamin D is not there, it becomes very difficult for absorption of calcium. Some amount of calcium can be absorbed paracellular. So this is transcellular absorption. Some amount can be absorbed as paracellular. When the levels are very high, paracellular becomes more and more prominent. When the calcium levels in the diet are very low, the transcellular mechanism is very much active. Next, parathyroid hormone. It also influences the absorption of calcium. How does it influences? It stimulates the calcium reabsorption. It doesn't have any direct effect, but it helps in reabsorption of calcium by activating vitamin D. So what will it do? Vitamin D 25-hydroxy, the vitamin D is present in the form of cholecalciferol, and in the body it is activated to form 125-dihydroxy cholecalciferol. 25-hydroxylation occurs in the liver, and hydroxylation at the first position occurs at the kidneys. So the enzyme that is required is 1-alpha hydroxylase. The renal 1-alpha hydroxylase synthesis is much and more activated by parathyroid hormone. So it helps in parathyroid hormone, indirectly helps in activating vitamin D. Now we'll see what are the factors that decrease the absorption. So till now we have seen acidity, presence of amino acids like lysine and arginine in the diet, presence of vitamin D increases the absorption. Along with that, parathyroid hormone also increases the absorption, but it doesn't do it directly, it does it by activating the vitamin D. Now we have to know what are the factors that decrease the absorption of calcium. Phytic acid in the diet, because the diet that we take is a mixed diet. We don't take specifically only carbohydrate or only lipids or only vitamins like that. Our diet is mixed diet. So our diet will have multiple things. Like when we take cereals, the cereals will form insoluble calcium salts, and the presence of the cereals will have a special substance called as phytic acid. This phytic acid will form insoluble salts with the calcium. So once the calcium is precipitated or it forms an insoluble salt, it becomes very difficult for its absorption. So it has to be avoided. Then oxalates. The oxalates that are present in some of the leafy vegetables, they also cause the formation of oxalate stones, calcium oxalate stones. As a result of that, the absorption is also decreased. Fiber. More and more fiber in the diet interferes with the absorption of the calcium. We have to consume fiber in the diet because that is very much important. The roughage in the diet that has got very good effect, but do not consume to a very greater extent that it inhibits the absorption of calcium. Malabsorption syndrome is a disorder in which the fats are not properly digested. The fats that we take in the diet, they are not properly digested. As a result of that, absorption does not occur. So what will happen in malabsorption syndrome? Fatty acids are present as such like that only. So these fatty acids, and this is Ca+2, fatty acids, H will be lost, it will be COO minus. So as a result of that, calcium will combine with the acid and it will form insoluble calcium salt of fatty acids. In that way, it will also prevent the absorption of calcium. Next are glucocorticoids. The glucocorticoids decrease the intestinal transport of calcium. Phosphates. Presence of high phosphates in the diet will cause the formation of calcium phosphate. As a result of that, calcium is not absorbed. Next is magnesium. Higher amount of magnesium in the diet decreases the absorption of calcium. Next, We'll see the functions of calcium. For us, you have to just learn what are the functions of calcium, because the most important is, okay, we'll go into the development of bones and teeth. For the development of bones and teeth, bones, as I told you, 99% of the total body's calcium is concentrated in the bones. So you can imagine calcium is the major mineral that is present in the bone. Bone is regarded as mineralized connective tissue. The connective tissue would be normal. Only when it gets mineralized, it becomes so strong. The bone acts as a reservoir store for calcium. The bulky quantity of the calcium is used for bone and teeth formation. Osteoclasts induce the bone deposition and osteoclasts produce the demineralization. So osteoclasts are the ones that will help in mineralization of the bone. Osteoclasts are the ones that will cause demineralization and they destroy the bone cells, osteocytes. The bone cells are osteocytes that are destroyed by the osteoclasts. So, number one function is bone and the muscle. Major constituents of the bone, number one is in the bone and the teeth. The major mineral that is present in bone and teeth is calcium. Next, about the muscle contraction. For muscle contraction, calcium is very much required. What does it do? It mediates excitation and contraction of the muscle. How does it do? It does the excitation and contraction of the muscle by activating ATPase. It will be activating here you can see it will be activating the ATPase and increases the action of the myosin and the actin. So this is a myosin, and in that way it will be increasing the activity of the myosin. Calcium decreases neuromuscular irritability. So in that way, when calcium binds to it, action potential causes depolarization and release of the calcium. So once the calcium releases, calcium exposes the myosin binding sites and myosin heads towards actin. As a result of that, muscle contraction will occur. And at the same time, it also decreases the irritation that occurs at the neuromuscular junction. That is why deficiency of the calcium will lead to a disorder called as tetany. Next is being a neurotransmitter. How does it help in being a neurotransmitter? Once the action potential arrives, it opens the voltage-gated calcium channels. Once these voltage-gated calcium channels are opened, calcium influxes into the terminal transmitter. It fuses and releases by means of exocytosis the neurotransmitter. So, when the action potential activates, the voltage-gated calcium channels are open and calcium will be entering into the neuron. It will be entering into the terminal part of the neuron, and when it enters in terminal part of the neuron, once calcium enters, this calcium will fuse with and releases the neurotransmitter. In that way, it will be helping in in that way it will be acting. It will be helping in release of the neurotransmitters. Next, another important thing is it activates a clotting factor. Calcium is finally required for activating the clotting factor. It assists in maintaining all cells and connective tissues in the body and regulate the mitotic transition and cell division. It is an essential component in production of enzymes, hormones that regulate the digestion for energy purpose and for fat metabolism. So these are the functions of the calcium. And another important thing, it is required for the formation of the bone and teeth. It is required for muscle contraction. It is required for the neurotransmission, for the release of the neurotransmitters. It is required for the clotting purpose, for a digestion, and all the digestive enzymes will depend upon the calcium, and along with that it is required for cell division, enzymatic activity. For all these things it is required. Another most important function of the calcium is acting as a second messenger. What is a primary messenger? The primary message is always given by the hormones. Secondary messenger means the transmitted into the nucleus, so that part is carried out by means of second messenger. Calcium and CAMP are second messengers for various hormones like epinephrine in liver glycogenolysis. In liver glycogenolysis, epinephrine, once it sits on the liver cell, on the hepatocyte, on epinephrine site, it will activate the calcium and CAMP and subsequent reactions will take place. And calcium also serves as a third messenger for some of the hormones. like ADH acts through CAMP and then by calcium. Now, what is the second messenger? We'll see. Normally, this is a particular cell. Now, this cell, the calcium channels are there that are closed. And now this is a hormone. This is a hormone receptor. Now, when hormone is not there, when hormone or no activation of this receptor, the calcium channels are closed. That is what we observe throughout the cell. Now, the primary messenger has come, that is the hormone. It's add onto its receptor. So once it sits onto its receptors, it opens the calcium channels. The calcium channels are open and the calcium will influx into the cytosol. Once it gets influx into the cytosol, calcium and calmodulin that is present in the cell, calcium binding form. The calmodulin was also active till that time. Once calcium enters, calmodulin is activated. It forms a calcium and calmodulin complex is formed. Now this calcium and calmodulin complex is very much required for activation of the enzymes. So it will activate the enzymes and the substrate will get converted to the product. So this is how it acts as a second messenger. Calcium channels are closed when there is no hormone at the receptor. Once the hormone sits on the receptor, calcium channels are open. Important step is calcium will bind with calmodulin. The vitamin D is producing cal binding in the intestinal cells. You have cal binding. It is binding the calcium. So it is cal binding. This is calmodulin. It is modifying the calcium so that it will activate the enzymes. It doesn't modify the calcium, but calmodulin is required for the enzyme activation. So it is modifying the enzyme so that the reaction will take place. So this is how it acts as a second messenger. There are two mechanisms by which, so this is a calcium calmodulin pathway by which the calcium acts as a second messenger. There is one more mechanism by which it can act as a second messenger, that is by means of phospholipase C. Now, what will happen? Now, here and what we have talked previously is the calcium that is present outside the cell, it has to enter into the cell to do this process. Now, sometimes the calcium is not present outside. Internally, the calcium that is present, it will come into the cytosol to activate the enzymes. So, the endoplasmic reticulum is the one that stores calcium inside the cell. So, in the cytosol, it is not present as such. It is stored in endoplasmic reticulum. Now, the hormone sits on the first messenger or hormone sits on the protein, specific protein called as G protein. Once it attaches to the G protein, the GTP will bind to the G protein and in presence of an enzyme called as phospholipase C, it will divide into the phospholipid that is present on the cell membrane. The phospholipid that is present on the cell membrane will phosphoinositol diphosphate and diacyl glycerol. It will form the phospholipid will get divided into PAP, that is phosphoinositol diphosphate and diacyl glycerol. In that way it will get divided. Now, after this, by another step, it will form inositol triphosphate. Now, this inositol triphosphate that is formed, it acts as a messenger. It sits on the calcium gated channels and this calcium is released from the endoplasmic reticulum into the cytosol. So, now this calcium, once it comes out, it will combine with the calmodulin and it will do all the cellular responses it has to do. So, this is another mode by which it acts as a second messenger. Previous one that we saw is in this mechanism, when the hormone sits on the receptor, the extracellular calcium will be entering into the cell. Whereas in this, there is no extracellular calcium. Intracellular calcium that is present inside the endoplasmic reticulum will release into the cytosol. This is mediated by means of inositol pathway. What will happen here? Inositol triphosphate will be helping in opening up of calcium channels of endoplasmic reticulum. Now, from where are we getting inositol triphosphate? We are getting it from the phospholipids that are present on the cell membrane. And what mediates it? It is mediated by means of phospholipase C. So I think there is no confusion regarding the two types of second messenger. In the previous one, the extracellular calcium will enter into the cell, and here the calcium present in the endoplasmic reticulum will enter into the cytosol. So this is activated by another pathway, inositol triphosphate pathway, that will help in mediating this. But always remember, once calcium comes out into the cytosol, it always gets associated with the cal module. To do other metabolical functions, it has to get associated with the cal module. So how calcium acts as second messenger, we have seen both the mechanisms. Calcium homeostasis. Now, calcium being such an important thing, it is required for the bone, coagulation, muscle contraction, neurotransmission. It acts as a second messenger, and I already mentioned you that the range is 9 to 11. So, the range is very, very narrow. So, there should be a very tight regulation for calcium. So, this calcium homeostasis is a very important essay for you. It can come as an essay. They'll ask you calcium homeostasis, in which you have to mention what they'll ask you, what are the functions of calcium, and write in detail about the calcium homeostasis. Or as such, you will be getting a question like calcium metabolism, where you have to start from absorption of calcium and you have to absorption functions. All these things you have read: absorption functions, homeostasis, and deficiency manifestations. If the calcium metabolism is given, or else calcium homeostasis, it can come as short notes also. So the three primary hormones that are required for tightly controlling the calcium in the body are intestine, bone, and kidneys. These three are very much required. And what are the hormones that will be controlling it are parathyroid hormone, vitamin D, and calcitonin. Now, how vitamin D has come up as a hormone part? Why do we call vitamin D as hormone? Because the mechanism of action of vitamin D is exactly same as that of any steroid hormone. Like sitting onto the DNA, transcribing a particular protein, from that a particular protein is translated. So the mechanism how it acts is similar to that of a steroid hormone. That is why it is put in under hormone session. So in that, the calcium homeostasis, the calcium level, extracellular calcium has to be maintained 10 mg per deciliter. So if the levels are low, what will happen? Absorption of calcium will occur. If levels are very high, secretion will occur and it will get excreted. Now, if the levels are very much high, the bone will be taking up, or calcium will get deposited in the bone. And if the levels are very low, bone desorption will take place. That is mediated by parathyroid hormone and 1,25-dihydroxycholecalciferol. Next, another part in which it is regulated is excretion part. If the levels are very low, it will help in reabsorption. That is aided by means of parathyroid hormone. If the levels are very high, via the filtration, it is lost in the urine. So this is how calcium is regulated. Now we'll see details of each one of them. Role of calcitriol on bone. Vitamin D. As we have already seen that vitamin D is required for absorption of the calcium. Now what does it do on the bone? Osteoblasts, there are two types of cells. As I already mentioned, there is an osteoblast and osteoclast. Osteoblasts are bone forming cells, osteoclasts are bone destroying cells. In osteoblast of the bone, calcitriol stimulates calcium uptake for deposition of calcium phosphate along with parathyroid hormone. So this is the first step where it will be helping in mineralization of the bone. But when parathyroid hormone levels are very, very high, it will help in mobilization of calcium and phosphate from the bone. So normally if the calcium present in the normal range, then mineralization of the bone will occur. If they are decreased, then demineralization of the bone will occur. And in that way, it will increase the plasma calcium and phosphate. Calcitriol on kidneys. Calcitriol minimizes the excretion of calcium and phosphate. Here we have to remember that calcitriol in the kidneys, it decreases the excretion of calcium and phosphate. Calcitriol in intestine. We have already seen that calcitriol increases the intestinal absorption of calcium and phosphate. So here what we have to remember is in the bone, if the levels are normal, it will help in mineralization of the bone. If the levels are low, in association with PTH, that is parathyroid hormone, it will cause demineralization of the bone. Action of calcitriol on kidneys. Calcitriol decreases the excretion of calcium and phosphate. calcitriol increases the absorption of calcium and phosphate. So everywhere whenever calcium is being protected, phosphate is also protected by vitamin D. So in this way, in the bone, it will cause resorption, increase the calcium and phosphate. In the kidneys, it will cause reabsorption of calcium and phosphate. In the intestines, it will increase the calcium level, it will increase the absorption of phosphate by synthesizing calbindin. Parathyroid hormone. How does parathyroid hormone act? It is secreted by the chief cells, and it is secreted by the chief cells by the parathyroid gland that is present posterior to the thyroid gland. The rate of formation and secretion of the PTH are prompted by calcium concentration. So they are present in the posterior aspect of the thyroid. There will be 4 small nodule-like things that are attached to the thyroid. So these are secreted by the chief cells of the parathyroid hormone or parathyroid gland. The rate of formation is mainly, that is, low levels of calcium. The PTH is very much sensitive to low levels of the calcium. Parathyroid hormone. The parathyroid hormone released. What will it happen? It increases the calcium level. It increases the calcium release from the bones. That is what it do. It will help in reabsorption of the calcium from the intestine. How does it help in absorption of the calcium from the intestine? By activating the calcitonin, that is vitamin D. It will increase the calcium reabsorption from urine. From the kidneys. Action on bone. It causes resorption by decalcification and demineralization by osteoclast. This is brought about by enzymes such as pyrophosphatase and collagenase, which ultimately lead to an increase in blood calcium levels. Action on kidneys. The PTH increases the calcium reabsorption by the kidney tubules. It is very rapid and it elevates the blood calcium levels to very high. And one more thing is that it also induces the production of calcitriol, that is 1-alpha hydroxylase, and in that way it will promote the reabsorption. Here one more thing that we have to remember regarding the action of kidneys, parathyroid hormone's action on kidneys, is that the parathyroid will absorb the calcium at the cost of phosphate. It will eliminate the phosphate and it will absorb the calcium. So the activity of the parathyroid hormone is only limited to calcium, whereas that of the vitamin D is for both calcium and the phosphate, whereas for PTH at the kidney level, it is limited only to the calcium. Action on intestine. As we know that the parathyroid hormone doesn't have a direct action on the intestine. It acts just by activating calcitriol. Now next, so these are the two things that will tend to increase the calcium levels in the plasma. Now there is one more hormone called as calcitonin that will decrease the decreasing the calcium levels in the plasma. So it is a peptide that is produced by the parafollicular cells of the thyroid gland. Its action on calcium is exactly antagonistic to that of the parathyroid hormone. It promotes calcification by increasing the activity of osteoclast. So it is completely pro for calcification and it increases the activity by increasing the osteoclast. It decreases the bone resorption and increases the excretion of calcium into the urine. It has decreasing influence on blood calcium. So this is how it happens. If the calcium levels are too low, first we'll start from here. If the calcium levels are too low, calcium homeostasis has to be maintained. But because of some reason there is decrease in the calcium level, what will happen? The parathyroid hormone is immediately senses the low calcium level. It increases the calcium release from the bone. It increases the uptake of calcium and it prevents the elimination of calcium. And it will be helping in reabsorption of the calcium and decrease the excretion of calcium from the urine. Now, when the levels have become too high, the calcitonin gets activated. It is released by the thyroid hormone. It causes the mineralization of the bone. It will help in the deposition of the bone. It will decrease the uptake of calcium by inhibiting the activation of vitamin D. It will decrease the reabsorption of calcium. In that way, the calcium levels fall and it will come to homeostasis. This is how the parathyroid hormone and the calcitonin maintain a balance They maintain a balance so that calcium homeostasis is being maintained. Now, serum protein. So, these are the factors that absorb along with that serum proteins. When the albumin levels are decreased, total calcium level is decreased. Metabolically active ionized calcium is active because ionized calcium is not bound to protein. It is completely free. So, its levels are not decreased if there is decrease in the serum protein levels. Alkalosis and acidosis. Alkalosis favors the binding of calcium with the proteins with consequent lowering of ionized calcium. So, alkalosis promotes the binding of calcium with the proteins and acidosis favors ionization of the calcium. Next, the renal threshold of the calcium is up to 10 mg per deciliter. If it crosses 10 mg per deciliter in the blood, it will start appearing in the urine. Hypocalcemia. When do you call the term hypocalcemia? When the levels are below 8.8 mg per deciliter, you call it as hypocalcemia. It is calcemia. Calcium is decreased, hypo means decreased. So, calcium, hypo decreased, calcium, mia means in the blood. Most common is vitamin D deficiency, hypoparathyroidism, increased calcitonin level, defective absorption of calcium, renal disorders, and deficiency of magnesium. So, all these things will cause hypocalcemia. Now, what are the symptoms of hypocalcemia? All these things are done detailedly in your physiology. So, just I am mentioning the names. Neuromuscular irritability will be there. Paresthesis will be there. There will be bronchospasm or laryngospasm. Tetany is very, very rare. The person could have seizures. They will be having Chopstick sign and Drazu sign. What do you mean by Chopstick sign? When this is stimulated, when you hit at the mandible, there will be clinch will occur here in that way. Some contraction will occur here, that is called as Chopstick sign. Next is Drazu. When the BP apparatus is bind and the cuff, when the BP apparatus cuff is tied to the arm and when it is inflated, you can see a special manure like that. So, this is called as Drazu sign. In that way, special manure develops, so that is called this sign. Next, prolonged QT, like in the ECG, you learn ECG, in that there is prolonged QC time on ECG. Causes of hypercalcemia, hyperparathyroidism, multiple myeloma, Paget's disease. Most of the bone anomalies are associated with increased calcium level, like metastasis of the carcinoma of the bone, thyrotoxicosis or Addison's disease, benign familial hypercalcemia, dehydration, prolonged immobilization, tuberculosis, leprosy, all those things, some of the drugs, all these things are responsible for hypercalcemia. Now, what are the symptoms of hypercalcemia? The symptoms are anorexia. Anorexia means not feeling like eating. Nausea, vomiting. Polyuria and polydipsia means increased thirst and increased frequency of urination. Next, confusion, depression, psychosis. Osteoporosis and pathological factors are much more common because calcium is present in the serum but it is not getting deposited in the bone. Renal calculus, the calcium, more of calcium that is present in the blood will get precipitated in the kidneys. It will form renal calculi. Ectopic calcification, that is calcification in other specific organs, will also occur. The serum alkaline phosphatase levels are also occur. The serum alkaline phosphatase is the one that will help in mineralization of the bone. So, the levels are increased. Now, what do you mean by the term mineralization of the bone? Mineralization of the bone means the process of deposition of calcium and phosphate in the osteoid of the bone. The osteoid of the bone means the connective tissue of the bone and the matrix of the bone is called as osteoid. So, the process in which the connective tissue of the bone gets associated with calcium and phosphorus, you call it as mineralization. The osteoblast, and now from where do we get this osteoid or connective tissue? It is produced by osteoblasts. The factors that are required for mineralization of the bone are alkaline phosphatase. This alkaline phosphatase will provide phosphate because the phosphate is associated with some other components in the bone. So when calcium enters into that, this alkaline phosphatase will break down. It will help in breaking down and it will be releasing the phosphate so that calcium and phosphate will combine to form a salt. Then osteocalcin. Osteocalcin is a type of the protein that is present in the bone that is increased when the mineralization of the bone occurs. Next is osteonectin. This is also a particular protein that is present in the bone and that is required for mineralization. Now, so to conclude with, we'll be comparing the action of because as I told you, most important part that we have to learn in this class is calcium homeostasis. How calcium is regulated, how calcium is absorbed, and what are the deficiency manifestations of these things. So to conclude with, before concluding that, I just want to repeat them again. I want to tell you how to compare. I want to tell you the comparison of action of the three major factors that affect the serum calcium. Now, what is the important trigger for these three things are blood calcium levels. The blood calcium levels are increased by vitamin D. They are drastically increased by parathyroid hormone, because if the parathyroid hormone is not there, vitamin D will not get activated. So, drastically increased, calcitonin will decrease. What is the main action? Main action of vitamin D is to absorb it from the GAT is the main action. The PTH will increase the calcium in the plasma by causing demineralization. What does calcitonin do? It will prevent the demineralization. Calcium absorption from the gut. It is increased by vitamin D. It is indirectly increased by PTH, but does not have any effect by the calcitonin. Bone resorption. It is decreased by vitamin D. Bone resorption is increased by PTH and it is decreased by calcitonin. Deficiency of vitamin D can cause rickets. Deficiency of parathyroid hormone will cause tetany. Use in rickets, vitamin D is a drug of the choice. PTH is contraindicated because it will further deteriorate the mineralization. It will deteriorate and it will cause demineralization of the bone. So it has to be completely avoided. We can to some extent give calcitonin, but how much beneficial it is, we don't know. But theoretically, we think, yeah, because it helps in mineralization, it is required. But practically, how much it is useful, we don't know. Effects of the excess. What will happen if the vitamin D levels are too high? It will cause hypercalcemia. If the PTH levels are very high, it will cause very severe hypercalcemia. So it is 1 and this is +1. What will happen if you have more and more of calcitonin? It will cause hypocalcemia. That means the calcium levels are decreased. This PTH will drastically increase the calcium level. Vitamin D will a little bit increase the calcium, but drastically it is increased by PTH. So to finally conclude with, we have only 3 substances that will help in controlling the calcium, that will help in maintaining the calcium homeostasis: vitamin D, PTH and calcitonin. And on what sides do they act at? They act at bone, they act on intestine and they act on kidneys. So these 3 factors will act on these particular organs and they help in maintaining the calcium homeostasis. So for today's class, we are completing the calcium homeostasis. We have completed. This is a potential essay. So in the next class, we learn about iron metabolism.